All right, everybody. So this topic is going to be barriers to medication adherence. It sounded like the group really wanted to have some information around adherence and things to look out for as far as signs of adherence issues that might inhibit treating their patients for hepatitis C. So that's what we're going to kind of go through today. The objectives you can see here. So we're going to kind of go over what is adherence, what you might see in the literature as far as terminology, things to look out for as far as barriers to adherence, starting patients on therapy. I have a study and some information to go over specifically for adherence that's been looked at in hepatitis C patients, and then look at ways how we can help our patients to overcome any of those barriers. So starting out here, just some terminology to kind of run through. Adherence is the extent to which your patient is taking the medications as you have prescribed them. You might see some different definitions throughout the literature and terminology, and there is a lot of information out there on whether it's appropriate to use the term adherence versus compliance. The issue with using compliance as far as the literature is concerned is that it sort of has a negative connotation with your patients, that they're just taking it as ordered without any sort of input, versus adherence is more thought of to be a more collaborative agreement between you and your patient and how they're going to take the regimen as you've prescribed it. So that's why in the literature you see more of a shift from using the terminology of compliance to a regimen to adherence. Something else that you might see in the literature is using the term persistence. And really what that is just a definition, not specific to adherence, but while they're on therapy. So you've got initiation of therapy and termination, and persistence is that time between. It doesn't really say whether or not they're taking the medication as prescribed, just that they're taking it at that time period. So there's a little difference there in the terminology. And the next thing that they've really more recently come out with in the literature is the difference between intentional and unintentional non-adherence. There's a typo on the slide that I missed, so that's non-adherence. And what that is really putting the type of non-adherence from your patients into a bucket, and they both need to be looked at simultaneously when you're evaluating your patients for whether or not they're adherent to therapy. And it's exactly what it sounds like. So intentional adherence, I'm not taking this medication because it's too expensive, versus unintentional adherence where I might have forgotten to take a dose here or there. I didn't mean to not take it, I just forgot. And then a lot of debate in the literature about what is optimal adherence. You might see varying optimal adherence when reading trials on what they were shooting for with their patients. And obviously in something like treatment of hepatitis C, adherence is really important. So a lot of times you'll see optimal adherence quoted at 80% for chronic therapies, things like hypertension, COPD. You want them to be 80% adherent to their regimen, but obviously we're shooting for better adherence rates for our hepatitis C patients. So across the board, there's no specific optimal adherence. You do see that in HIV patients because we have a little bit more data on development of resistance and therapy failure with certain of the medications for HIV, but we don't have that cutoff on what optimal adherence is for hepatitis C at this point. So moving into what types of adherence we're looking at and what might affect that, the World Health Organization put out 5 different areas where adherence, you could kind of categorize those and where you should be evaluating those different types of adherence when assessing patients. So there are patient-related factors, and these are anything from how motivated the patient is for the treatment, whether or not they have any sort of cognitive impairment, visual impairment, any issues with whether or not they actually think they need to take the medication. So all patient specific. Another one to evaluate is the socioeconomic area, where this is health literacy. How much the medication costs. Does the patient have a stable environment? Are they homeless? Do they have transportation to get to the pharmacy and to your office? And then there are issues with the healthcare system as well, what their perceived patient provider relationship is. Do they have long wait times at the pharmacy to get their medications or in the office to see you, so maybe they don't make an appointment? Issues with formularies or their insurance. And then there are medical condition related. So these are things like whether or not they have symptoms, so something that we might see with our hepatitis C patients, or if they have really severe symptoms that are going to affect how they're going to take that. And then there's therapy related. So is the regimen that's being prescribed to them really complex? Is there a longer or shorter duration that we could use? Are they going to have side effects that are going to affect their ability to take it and take it correctly? So those are all things that we need to evaluate when trying to select a regimen for the patients to try to avoid those adherence barriers on the front side. This is from a study where they put together all of the different predictors of poor adherence, and you can see the associated study that those came from. So a lot of these things, I think, are probably things that you already see and already suspect and evaluate for when thinking of patients for adherence. So things we've already talked about with those different domains that the World Health Organization had mentioned, things like cognitive impairment, their relationship with you, and problems with complexity. And that plays into the next slide, where you can see from the same study, they pulled information on dosing frequency and how that impacts adherence. So the horizontal lines you see is the mean adherence rate for those, and then the vertical lines is one standard deviation from that. And it's once versus twice, 3 or 4 times daily regimens that these patients are taking. And as you can see, where it's a once daily regimen, it's about 80% adherence, versus the more times a day they have to take the medication, we see lower adherence rates around 50%, with anywhere in that one was reported 30 to 70% adherence. So it decreases dramatically when the complexity of the regimen increases. And that, I mean, that inherently makes sense. I know me personally, I'm much better at once a day medications than if I have to remember to take it more than 1 time a day. So our patients are human and they're going to have those same obstacles. And the reason that I wanted to point this out specifically is that when a lot of these medications came out, we had, originally we were using Sovaldi and Alisio. They were 2 pills that the patient had to take, but they were taking it once a day. Same thing with when we see Mavorite, yeah, they're taking 3 pills, but it's still once a day, versus some of the other medications that we don't, either off the market now or that we don't use as much, like Declinza, or I'm sorry, well, like Vicura, where that was often paired with ribavirin, so they have a higher pill burden, plus they're taking it more than 1 time a day. So that's going to impact their adherence. So if you have any suspicion for a patient to be non-adherent because of forgetfulness, kind of keep this in the back of your mind that a once a day option is going to be better than more than 1 time a day. And as far as measuring adherence, there's a lot of ways we can do this to evaluate whether or not the patients are adherent when they come in for their visits and we're looking at their medication. So the easiest thing is just to go by patient report. Are you missing any doses? This is really easy. It doesn't cost anything. The problem with this one is going to be patient recall. If they haven't, they're going to remember something more recently if they've missed a dose in the last week or 2, but that doesn't help you if you haven't seen them in 3 months if they don't remember over the long term. Patients also don't want to let their providers down, so they might fib a little bit about how adherent they are to their regimen, so it's not the most accurate. Something else you can do is pill counts. So again, this one's really easy to do, and you can identify adherence issues doing this. I know that there are some HIV clinics that do this, where they have the patients actually bring in their heart therapy and review and have do the pill counts. The con to doing this is that some patients will dump their pills to appear like they're more adherent than they actually are. So they bring less pills to the appointment so that you think that they're taking their medication as they're prescribed if they're missing some doses. So again, not the most accurate way to measure that. Probably one of the most accurate ways would be directly observed therapy. Make them come in, but how feasible is that for you to do, to have a patient come in every day so you can watch them take their HIV regimen? So that's really not something that we're able to do easily, but it is the most accurate. Another way you can do it is looking at pharmacy fill information. This is something that we do a lot in the specialty pharmacy, is look at medication possession ratio. So we're looking at how many pills do they have over a specific period of time, and we get that rate of adherence. The problem with this, although it's easy to calculate, is that it's not truly reflective of the patient's adherence. Just because they fill the medication does not mean that they're taking it correctly. So there are flaws to that one. You could look at their clinical response. So this is something that you're doing probably if you have them come in, using the surrogate marker from the hepatitis C standpoint of the HIV or hep C viral load. So you can see using that surrogate marker, they're taking the medication because their viral load has gone down or is undetectable. The problem is that doesn't mean that they're actually adherent to their therapy 100%. Similar with therapeutic drug monitoring, that's something that you could easily look at drug levels, but that's not something that's readily available to us from a hepatitis C standpoint, so it's not feasible for us to do. The last thing is the electronic monitoring. So these are special caps that you can put on the vials that actually keep track of how many times the vial is open and closed. So it's good to see, are they opening it and taking their pill out and taking it every day or multiple times a day? You can track that. It's really easy to do. They can bring the bottles, depending on how much these cost and the brand that you buy. There are some that can do this, over the internet. Essentially, whenever they're connected to internet, they can feed that information back to the system, or you have to have it so that you can download that. So they technically have to bring that bottle in to the clinic where you can download that information and evaluate it. Again, not perfect because these are crazy expensive, so it's not really feasible for our patients to do. And it doesn't necessarily mean they took the dose just because they opened and closed the bottle. They may not have actually taken the pill. So we have all these different ways. The TLDR version of these two slides is that we have a lot of ways to measure adherence, but none of them are perfect. They're all going to have flaws. So a lot of times we're using a combination of this information to try to figure out how adherent the patient actually is. And I wanted to pull up one study right now as far as actual adherence to the direct acting antivirals. We don't have a lot of studies that have looked specifically at it in a general population, but this is one study that looked at 3 different regimens, keeping in mind that this study was actually part of the Synergy study for Harvoni. So this was sort of an aside of, they were also looking at, could we shorten the duration of Harvoni even less than 8 weeks by adding different agents? So there were 2 parts to this study. So keeping that in mind, that these patients are in a clinical trial, so they're being watched carefully, so their adherence might be a little bit higher in general. But what they did here is they did Harvoni by itself, so 1 pill once a day for 12 weeks, the standard therapy. Then they did Harvoni plus another medication. So this was 2 pills, but still once a day, but only for 6 weeks. And then looked at Harvoni plus 2 other medications. And what this one was technically 3 pills, 3 different medications where they had to take three pills in the morning and 1 pill in the evening for that 3rd agent. So technically twice daily dosing for this one with a little bit higher pill burden, again for 6 weeks. And in this portion of the study, they were primarily looking at adherence. And they measured adherence 3 ways. They did the electronic caps, which was the MEMS system. They did the pill counts when the patients came in, and then patient reports. So they did questionnaires. So you can see the results here on the chart over on the right with all 3 adherence rates reported. So the MEMS, the electronic caps, are the black, the gray is the pill count, and the white is the patient reports. So as you would expect, the patient report is always the highest. But across the board, adherence was greater or equal to 95% no matter what regimen they were doing. So it still had good adherence. Some of the things that they found was that in the 12-week treatment, one of the issues they found on the questionnaires for patients that were non-adherent to the regimen was that they had used drugs. So in this study, it was cocaine, heroin, or marijuana within the 6 months leading up to the trial, or alcohol abuse currently. The interesting thing is both regimens that were 6 weeks long, the adherence rates were similar whether they were abusing drugs or alcohol or not. So they did not find that in both studies. And there have been several studies as far as active drug and alcohol use and hepatitis C regimens where it shows that it may or may not affect adherence rate, but doesn't appear to affect their SVR. So that's sort of still up in the air, but this is just what they found in this study specifically. Some more data in this study that they looked at is they found a trend towards lower adherence in the ones, the regimens that had a higher pill burden. So that's the bar graph that you see here, the first graph. And keeping in mind, remember that the traditional group was Harvoni times 12 weeks, but they only looked at the data in the first 6 weeks to match the other 2 6 weeks regimens. So this is, the bar graph is only the first 4 weeks of treatment. And what you see is their trend. So it wasn't statistically significant, but 1 pill once a day, there was more adherence than there was for 2 or 3 with twice-a-day dosing. And then interestingly, also on the line graph over on the right side, is that adherence declined over the course of the 12-week period. So this is only looking at the Harvoni once a day for 12-week regimen. And what you see there is that adherence was higher for weeks 0 to 4, then declined over 4 to 8, and then again 8 to 12. So it looks like the duration there, they're kind of falling off from an adherence standpoint. And really that kind of makes sense, because anything that's new, you really want to stick with. Like I'm thinking of like anytime I've ever started like an exercise regimen, like I'm super gung-ho about it at the beginning, but the longer I'm doing it, I kind of trail off. And that's kind of what you see here from an adherence standpoint, is at the beginning, they're really adherent, but they might start missing doses as they continue on. So really the take-home points from all of this information is how we can see whether or not our patients have any of those red flags that they might not be adherent. And the key takeaway from all the literature is to educate, educate, educate. Go over the disease with the patient so they understand the burden of their disease, as well as the medication. What do they expect as far as side effects, things to look out for, when to contact you, what to expect through treatment, after treatment, and how to take it, and kind of making the patient engage them in what they want to do, giving them options so they really feel empowered when they start the regimen, and then utilizing the teach back method. There's a lot of information in the literature about making sure that the patient understood what you're saying by basically asking them to repeat back to you, okay, what are the expectations? How are you going to take this? Just to make sure that they understood it. I use this a lot when counseling patients, just to make sure that what I said was clear, and just say, you know, just to make sure what I said was clear, tell me how you're going to take this. Tell me what side effects you might experience. And then you can see what did they comprehend while talking. And then if there's any issues and you find those barriers, tailor the regimen to things that might improve their adherence rates. So we can do that by a couple of different methods, specifically for patients that forget doses. Things that I always say is, what is something that you do every day? Because then you can just leave the medication there. Do you make coffee every day? Put it right in front of your coffee pot. So every day when you go to make coffee, you take your medication. Put it on your nightstand where you're going to see it. Set alarms. This is one, almost everybody has a smartphone now, so that you can tell them, go ahead and set an alarm. I actually had a patient who was like, I don't always have my cell phone, but I'm always at my computer. So he set an Outlook reminder to remind him every day to come up and say, did you take your pill? And he took it. And there's a lot growing now in the smartphone apps. If you go and look for medication apps in your smartphone, there are hundreds, and they're all, most of them are free. There's one that we particularly recommend to our patients because it's called Mango Health, like mango, like the fruit. And there's a picture of a mango on the app. And full disclosure, I don't get any money from Mango for this. It's not a commercial. But our patients like it because if you take your medication like you're prescribed, you actually get points. And they actually have options to redeem those points for like Target gift cards and things like that. So that's an extra motivator for the patient to take their medication, because they're like, oh, I can go to Target and get a $5 gift card. So there's a lot of those apps out there, but that's just one we use because there's that extra incentive for our patients to take the medication as it's prescribed. And as far as side effects goes, a lot of patients are, especially if they've been treated for hepatitis C before, are really in tune with, am I going to feel like I did when I was on interferon? How, is this going to be a problem? So really going over the side effects and what to expect so they don't experience something and then stop taking the medication, where they think like, this is from the medication, I'm not taking it. And then don't tell you until their follow-up visit that they didn't continue with the regimen. And then give them those mitigation strategies. If this happens, try this, so that they're already empowered, like, okay, they told me to expect this, and now I have an idea of what to do to help them continue on with the medication. Interdisciplinary team approaches are really big from an adherence standpoint in the literature right now, because they're demonstrating that no matter, I don't have specific, this person, this member of the team did this and this one did this, but it seems like having this entire team has really helped from an adherence standpoint, because the patient has resources. If there are financial issues, the social workers can help with them. Education standpoints, prior authorizations, so that the providers can really focus on spending time with the patient with the appointment, and then everybody else on the team has their role to make sure that the patient gets their treatment and continues on. And lastly, thinking about therapy complexity. So we've already talked about pill burden and multiple times a day. So what's the regimen that's going to be easiest for the patient, and make sure they're involved in making that decision so that they're empowered to continue on. We at the pharmacy will provide them with calendars or diaries to help them remember to take their medications, and then closely follow up with them. So for our Hep C, we're calling them at least every month. And another big thing is compliance packaging. You can go ahead and switch. So just in case you haven't ever had the opportunity to see the medications, both Mavorite and Zepatier come from the manufacturer in compliance packaging, which is really nice. And I have a lot of our patients that take these really like them. So what you see in the Mavorite is that there is a large box, and then in that large box are 4 of the medium-sized boxes, and that's, so the large box is a 4-week supply. The medium-sized box is 1 week of medication at a time. And you probably can't see it here, but there are actually punch-outs on the medium-sized box for the day of the week that they've taken it. So they can punch that out so they know what it is. And then each of the, at the bottom there, you can see the individual, they call them wallet cards or packets, where the 3 medications are in there. So the individual once daily dose is prepackaged, so they just punch all 3 of them out and take them. So each time they take that wallet card, they punch out on the medium-sized box what day it was, so they can keep track of it. And I can tell you that I've had patients where I call and say, how's it going? And they're like, oh, I just opened up my last box. I have a week left. So without prompting, without having to worry about pill counting and how many they've taken, I can see from when they started whether or not they're adherent and they've missed any doses because of the compliance packaging. And then Zepatier is similar. So it actually comes with 2 different cards, and they're 2 weeks at a time. So they're numbered day 1 through 14 on each of those cards, and then they just kind of follow the areas around, and they can know whether or not they missed a day based on how many pills that they have left. And they can tell me when I call them, oh, I just opened this card or something to that effect. So the patients do really like these. So if you're worried about a patient who might not be adherent, if there's no other underlying issue with taking either of these 2, they come in compliance packaging rather than the other meds that just come in a bottle. Okay, and then lastly, going back to the socioeconomic thing, is the financial burden. We all know that these medications are crazy expensive. And now from a Medicaid standpoint, now that we can treat everybody, Medicaid copays are $0 to $3. So at least in that instance, a little bit more affordable than what we see with the commercial payers. With Medicare and Medicaid, we cannot use the manufacturer assistance with those because they're government insurances, but we can use the patient assistance, things like the PAN network, Patient Assistance Network, or the American Liver Foundation, both of which have funds, which we use all the time to try to get those copays down for those patients. We primarily, like I said, use that for Medicare and Medicaid. Well, primarily Medicare, because Medicaid, like I said, is $0 to $3. But for patients that have commercial insurance, all of the manufacturers right now have some sort of assistance program that we can use to get that copay down to $5 or less. So we try to do that on the pharmacy side ahead of time so that the patient doesn't have to worry about this as much. So they're not worried about, should I take this? Should I not take it? Should I stop taking it? Should I try to split pills? Things like that to make it last longer. So those are additional ways we can just remove that barrier up front. So that's really all I have, just to kind of go over what those barriers are, how we can get around them, and what we see so far in hepatitis C. So if you guys have specific questions or things that you do as far as adherence goes and seeing whether or not your patient's engaged, I'd love to hear it. And if there's any further questions or anything specific that I could do a didactic on later, I'm happy to do it.
Awesome. Thank you so much. That was wonderful.
Sure.
You guys have any questions? Anything you want to talk about?
Hey, I was just curious, for Medicaid, now that we get to treat people, what's the preferred medicine on Medicaid? Is it Mavrite, or is it genotype specific? Like, are they just going to use a pan genotypic agent, or is it going to be? Does anybody know yet?
So far they have not changed their formulary. So they have pretty much all the regimens that are available right now are options. It depends some of the criteria. So if you're going to use Harvoni right now, they're still preferring that as an 8-week treatment. If they don't qualify for the 8 weeks, then you're going to have to use one of the other options. So if you want to do an 8-week treatment, you have Mavrite as the option as an 8-week treatment. Harvoni specifically, though, is still limited to 8 weeks. You're not going to get 12 weeks of Harvoni. But all the other regimens, you nailed it. It's going to be genotype specific. So they still have that, looks like a Chinese menu where you have this, and then you go down to this when these are your regimens.
It really does look like a Chinese. You're absolutely right. It really does look like a Chinese menu. It's really funny. Yeah, that's good. We were trying to think, now that we're going to have all these patients open up for treatment, like how to kind of get a workflow in place just here in the office with doing things. And we're going to do basically a checklist, kind of like it's, I guess, what Medicaid requires in order to do those things, but then also just when did they have their last blood test, their viral load, a couple of weeks into treatment, a few weeks after, to confirm SVR, all that sort of stuff, just so that we're sure that we're not missing anything on these people. But I guess what I was hoping to get at was, like, if we were just going to plan on using pan genotype, like if we on our end of things, just as a default for those people, we're going to plan on doing Mavrite for 8 weeks for the majority of those patients. I mean, it seems like that would be a pretty good place to start, unless there were other reasons to pick other medicines, unless I'm missing something. Does that sound pretty logical to everybody?
This is Kaylee, Greg. So, I mean, I love Mavrite. I think I use that probably the most. The only reason, I mean, even as far as like a genotype standpoint, that I tend to check them still is because just for epidemiological purposes, honestly, just so we have that data. And then also with cirrhotics, just knowing if it's genotype 3, you'll need to do that as an
Yeah.
testing.
Yeah, all of ours don't. Yeah, we do. I mean, we will do genotypes on all that stuff is part of the initial workup for those people. So from an epidemiologic standpoint, it's just once we, I guess, get into the treatment arm of all their care. I agree. I mean, it's just once if the medicine, and I actually didn't realize how it came. This was really helpful to see the fact that it comes in basically an advent calendar of antiviral medication. That's pretty awesome. And so I have a resident here with me, and he said he said, for $120,000, why the hell do they not all come that way? And it just seems like, how could the extra $1 worth of cardboard be the make or break point in a medicine that costs
for $120,000? They should come with chocolate in there too.
I know, right? I mean, that's not a bad. That's you talk about compliance. I
would adhere to my medicine with the chocolate.
Anyway.
Or a private coach, for that kind of money, you could pay somebody to watch them take their medicine.
Well, I think, kind of my approach as far as regimen selection, whenever you have multiple options, I mean, one of the first things is looking at their drug interactions, just because of the, estradiol with Mavrite, and then the statins with Mavrite are kind of the big ones that we see a lot. So taking those into consideration, and then the PPIs, of course, with the Clues and Harvoni. But if those become an issue, or they're not able to adjust those, I kind of just ask the patient, like, you either have options, you could do 3 pills that you punch out of a blister pack and take once a day for 8 weeks, or we could do 1 pill that's not, you don't have to take it with food. So you don't have to worry about that, because remember, Mavrite you have to take with food, so not everybody eats really consistently to be able to do that. But but it's 12 weeks, and do you have a preference? And sometimes they do, sometimes they don't. But I kind of use that approach just to help them. And then a couple of the other things, Rachel, your presentation's awesome. It was really good. But kind of like in the clinic visits, a couple other things I do to try to assess as far as adherence at our initial kind of treatment eval visit is, you know, first of all, just saying you're going to have one opportunity probably to get this treated, and you let me know whenever that time is going to be right for you. If you've got a lot of stuff going on right now, you're worried at all about not being able to take this at the same time every day, let's revisit it. You know, we have room for the most part to not have to see urgently. So you let me know whenever you're going to be able to adhere to this. And then I also bring in the cost and say you're basically swallowing, you know, $500, $1,000 worth of medication a day. So you got to take it seriously. And I think that kind of makes just sticks out a little bit to patients that they need to be responsible about it. I do wonder though, with the study you brought up about kind of adherence dipping off at 4 weeks, I don't know what everybody's practice is. We could talk about it, but I bring patients in at the 4-week mark. And then for instance, if they're on Mavorite and their viral load's undetectable at 4 weeks, I typically don't do an end of treatment SVR. I just bring them back in for the SVR12 if I'm not worried about compliance or if I'm not worried about ongoing viremia. So I just wonder if maybe I should be bringing them back a little bit more closely, because I rely on you guys making those phone calls. I don't actually see them in clinic again a lot of the time. So it's just a thought. Maybe I might start bringing them in more often. So how do you guys handle people that you're treating? How often do you see them?
We usually bring them back at 4 weeks for the SVR to see if it's effective. And then, you know, with the Mavorite, I was doing Boni, so we were seeing them at the.
I lost you. Hold on. Jonathan, we can't hear you. You kind of. Oh no.
Oh no. We lost you.
Can you try to repeat that? Oh no.
We call.
Okay, I was just gonna say we do one thing. We kind of forced our hand through
Oh my. Ah, darn it. Oh, well, he's gone. Okay. Go ahead, Greg.
I was just saying we call them every week. So like our pharmacy calls everybody every week. We just ask them what day of the week. We have to have a good phone number for you, and we'll call you everything. And either our pharmacy or my nurse calls them every week just to check and see how they're doing. You taking your meds? You doing okay? Have you missed any doses? You doing that sort of stuff? You know, this stuff costs $120,000 to make sure that you're taking your pill. Like, I mean, it's like we make sure that they're doing that, and then we have them come in. I don't necessarily see them for their blood tests at the 4-week mark. I end up seeing them for it at 12. But we do one in the middle of their course of treatment. We do another one there at the end to confirm SVR. But most of what we're doing is actually calling the patients, and we do it a lot.
Nice. I like that. That's cool. I lost my train of thought now. I don't know. I lost my train of thought, Greg.
Does anybody else have any questions?
I have a question that's kind of unrelated to the treatment adherence, but kind of related to what Greg said a while ago about getting these folks treated and how we should go about that. So I've got kind of a pile of patients who have not qualified for treatment that we're trying to re-identify, and we're going to run reports. And so hopefully I'll have a big list of those patients soon, and my lovely medical student here has agreed to go through those patients and help us kind of fill out their echo forms and look at their old labs. And so I know Medicaid is still requiring that we have that echo consultation on there. So can we just do like a blast of all of these patients, like in one big, here's everybody that I've seen in the last year that didn't qualify for treatment?
Mm-hmm. Yep, is that approved? Yep, okay, we can do it. Hey, so yeah, sure, totally.
Okay. So once we have a stack of those, we'll just put them all in at once.
Yeah, that's totally fine. We're also doing an on-demand echo version for this, for Hep C and HIV, where if it's an urgent thing and you can't wait, like, I don't know, if it's like you turn it on a Friday after a session and you can't wait until the next session comes or something, just let us know and we'll get it addressed in like, I don't know, about a week,
I mean,
and get it back
long.
to you guys.
Cool.
Just so you have that consultation there. And then, you know, if it's a really fun case, obviously we can talk about it here. But that way the patient gets treated timely instead of having to wait, because there is going to be influx right now.
That sounds great, because it's going to be really probably just boring, straightforward cases.
Okay.
That's fine.
That's fine
Yeah,
too.
we were really trying to do that as an alternative, just because of a backlog of cases, just from having them overall. And so Dr. Gilfus and myself, I mean, we both can review them, but on that echo form, when you fill it out, there should be a drop-down box where you can choose on-demand, or is it educational? Is that the other option? But if you choose on-demand, then I think the case report will just come to myself and Dr. Gilfus, and then we can refer, you know, just review it and give you the recommendations. And then, like Caitlin said, if you want to present it at a session in the future, that's fine, but then at least you have that consultation, so it's not going to hold you back.
Right, and so we'll just get an email back with your recommendations.
But you don't have to like bulk them or anything. I mean, honestly, just as they come through, you can if you want, but if you have a few cases kind of coming through, that way we'll probably be timelier with response if we are just looking at them and sending them back rather than having to review like 10 at a time. It might just take us longer.
Okay.
Also, either way, but yeah, you don't have to bulk them, but you can.
Yeah, I was going to say, we'll make it all work.
Okay, that sounds great then.
Jen, did you want to?
Yeah, I have a question that's not really, it's tangentially related, and I would pose this to everybody, hub and spoke. I'm getting referrals primarily from our MAT program, people who have Hep C, and I'm finding that the bulk of them don't show up. And I've dedicated 40 minutes in my schedule for those patients, just because I like to take my time. They're mostly people I don't know, and I like to make sure I'm getting information and build a little rapport. So it's obviously a problem for the day when they don't come, but more importantly, they're still out there untreated. And so, I have my own ideas about how we could try to encourage people to come in. We've already tried calling them beforehand, and even then, they don't show up. It was funny, somebody in the lunchroom recently said, yeah, why don't they come in? And I mean, it seems obvious to me that there are probably a lot of complex reasons why people don't come in at all for treatment. So it's like appointment adherence, not even a treatment adherence at that point. But I wonder if anybody out there has dealt with that specifically with patients who have substance use disorder, and if you have any suggestions about.
Hey Jennifer, when you're doing it, are you involved in the M80 in your MAT program at all, or no?
Yeah, and that's going to change in January, and so I'll have a direct contact with people, which I'm hoping will help.
That's actually what we've done. Is we're actually in the process of starting a MAT program here, and the thought with how we've sort of done a soft start, the sort of thing, we have a couple of patients that we're doing, and then when we actually have the full clinic, we have a provider that's going to be doing exclusively that. But the idea is to kind of incorporate not just is like you're going to go over here and do your MAT stuff, and then you're going to go, you get referred to your primary care doctor who then does this other stuff. It's actually that I will go over there and do a clinic for those people while they're there for their MAT stuff. So it'll be kind of integrated, just so that adherence, because they show up for that, right? So it's like they show up to the MAT, you know what I mean? So it's like, but it's even like we're going to do a vaccine clinic there. So we're going to give them flu shots and tetanus shots and Hep A and B vaccines. I mean, the whole, like all of that sort of update their MMRs, 23, like the stuff that just gets lost and follow through. But those are actually the people that are, going to integrate PrEP too as part of that. So like those are going to be the three arms of it, is just kind of basic primary care, immunizations, and then prevention and treatment. And this would fall into kind of the prevention and treatment arm of that. So we're going to do this. I mean, we're going to treat hepatitis C as part of the MAT, like kind of as the same sort of thing. So when they're doing group therapy, when they're doing their Suboxone, Subutex, whatever it is, like they're doing the thing, or Vivitrol, they're going to be doing all that stuff, and they'll see me, and it'll be kind of all on the same day, so that there's not this division of, oh, okay, this is the place I go to go get my pills for my addiction. Oh, and they also want me to go see this guy that I don't know. Right. And at this other locate, like that sort of a thing. We're going to try not to do it that way. We're going to try to do it, integrated as best that we can. Then if they find their way over into my regular primary care clinic for, I don't know, whatever, if they have high blood pressure or diabetes or any of the other things that kill even more people, then that's fine. But it's not going to be, it's not, the idea is, I mean, we would not hold, like if they say, no, I don't want, I don't know, whatever, I don't want a flu shot. Like we're not going to give, we're not going to not give Suboxone, although that would probably increase vaccination rate. But it's, so that's how we're going to try to do it. So
great. Okay, that's really helpful. What I should do, we're planning for me to start at the MAT clinic in January, so maybe I should just plan to integrate them, because I don't. Anyway, that's very helpful. Thank you.
This is Kaylee. I think that's such an awesome idea. I mean, honestly, awesome. You should see if you should get grant funding for it.
That's what fancy people do, grant funding. That's like you guys are fancy people, man.
Feinberg know about that, because man, she'd be getting you money coming in right away. Like that's not really my angle either, but it's just something that it's a novel.
That's nice of you to say. Yeah, I appreciate that. I just think it makes too much sense not to do it that way. I don't know. The reason I want to do it that way is because the patients of mine that I have treated for their hepatitis C, they are the best vaccinated patients in our entire clinic, right? These people, they come in, they're like, do I need my flu shot? I mean, it's amazing. It's like how well they've been vaccinated against everything that they need. They're really well. I mean, they're a case presentation in all of their preventative measures, because they've just done such a good job assuming their care. Patients that are struggling with substance use disorders, just getting them to start doing that is an enormous. I mean, that's a huge step, and taking the barrier away from that, I think it'll make good sense. Plus, it avoids sitting around, in a 40-minute slot waiting for somebody not to show up. That's right. The thing. Nothing's right. Disruptive. Originally, what they had wanted, what my company had approached me about doing, was actually just moving my practice over there to that location and doing that. I don't really want to do that, because I'm afraid what would happen is it would just be this muddled mess. So what we're going to do instead is I'll keep my primary care practice here doing that, and then I'll just do that separate clinic over there, specifically targeted towards that, so that I don't have my regular primary care patients walking in over there trying to get seen. It would just try to make it as focused as we can.
Just one other comment about systems, and this might be too arduous for people to consider, but so far it's working for me. And I had asked a question about this earlier, but I created a spreadsheet that is secure and that has my Hep C patients on it, and just because I don't know them, and so I wanted a way to keep track of, have they gotten their labs? Have they gotten their vaccinations? Have they gotten their ultrasound? Have I filled up my ECHO case form? Have I presented to ECHO? Have I sent in the medication? Have they started medication? Have they gotten their repeat labs? And so for example, with this change in the Medicaid prescribing requirements, I have a list, so I'll just go to it. And so I'm really happy that I started doing that. It takes a little bit of time, and so far, in order to keep it secure, I'm the only one who can touch it, which that will change once I get more patients, because it needs to be a support service. But anyway, so just if, just in the interest of sharing systems strategies, because it's really systems of care that we're developing.
Yeah, that's awesome. And definitely, I want to hear about everybody's way of checking and tracking everybody, but I definitely think that's a good idea and a good way to do it. Joanna and Jessica, do you guys want to do your case? Yes.
Sure.
Great.
Sounds good. Okay, so this is a patient that Jessica has seen several times, so I'm going to let her present him. And so Jessica, he's got kind of, this is all the stuff that you put into the online thing. So they have control of that, so she'll kind of scroll down as you go through it.
So this is a 26-year-old male, not Hispanic, Latino, white. I say all this other stuff.
Yeah, you can kind of just go through.
So route of transmission was via IV drug use and then non-professional tattoos. He's treatment naive, Hep C positive, genotype 3, been vaccinated. Not a lot of other interesting history on him. Any particular labs that you want mentioned?
No, I think his labs were pretty straightforward. His viral load, if I remember right, was relatively low, right?
Yeah, so it was like 620.
Yeah, so his viral load was 620, which is super low. And he didn't have any major, it was F0. He's somebody that I would have just said, you know, congratulations, your liver is doing a great job at handling this Hep C for the moment. Now he is he's a guy that I think had just tested positive within, do you remember, was it within the last year that he found out that he had Hep C?
Yeah.
So my questions with him were, just kind of looking if there were other concerns with medications as far as drug choice, but also with his viral load being so low and him being a relatively new diagnosis, would you treat him right now? Would we jump on that? Or would we maybe give it 3 months and see if he goes to 0 with his viral load, see if he's somebody that's relatively new onset? So history-wise, he has been in jail within the last couple of years, but I think, if I remember exactly right, that he's been out of jail for the last year, and he's been on drug court doing regular drug screening, and his last IV drug use was a couple of years ago. So he hasn't gotten any new unprofessional tattoos recently, and he hasn't used IV drugs for a while. So to his knowledge, he hasn't had any new exposure. He really thinks he's probably had this for a while, but we can't be totally sure about his personal contacts and things like that. So I guess that's my big question is, should we treat him right now, or should we give it 3 or 4 months and recheck his viral load and see if it's going up or down? Now, he's about to get off of drug court and off of home confinement. So I'm a little worried that if we don't treat him now, he may go out into the world again, and I may never see him again. So with all that being said, what would you guys do?
Do you guys want to go first? Offer your thoughts, insights?
Is that literally 620, not 620,000?
620, correct.
I think he sounds like somebody would be safe to wait. I'd probably wait 3 or even 6 months and check another viral load and see where, unless you could dig up the old one. The problem is with a lot of these people that they don't have an old one. They just screened positive, which could mean for that guy, really, I mean, he could have had genotype 1 and cleared it and then just always screened positive forever, and then got genotype 3 and now is in the process of clearing it. So you don't really have a good timestamp other than the one that you have, the one that you did. So I would probably err, especially since he's an F0 and as long as you can keep him from using, which is always the challenge, right? So I'd probably wait and test him again.
Okay.
I kind of had the opposite thought, actually. I'm thinking you've got the bird in hand right now, you know. So probably there's no right answer.
Yeah. If the medicine costs $12, it would be, you know, no question, right? We treat
Yeah, if this was strep throat, you would have treated him the first time you met him, but it's like that's the yeah.
What does the patient want?
He wants to be treated.
Okay.
So, and we had an antibody positive for a long time, but I don't have another viral, I don't have an old viral load or an old genotype that we can look to.
I mean, both options look good. I mean, my concern is the compliance. If it does not come back, okay, then you're going to lose that patient forever. That's my thing. Otherwise, with such a low viral load, if a patient is compliant, we can monitor him. That is a better option.
With such a low viral load, I feel like he could just take 2 pills and probably be done with it. Wouldn't have any virus left.
Yep. Oh. This is Kaylee. I think you guys all have really awesome points, and both options are definitely plausible with this guy. My approach would probably be, you know, if he's getting, so first of all, aside from, you know, there's a couple different approaches that we would take as clinicians, but, you know, does he have Medicaid? He's
yes.
Medicaid. They're going to require 2 separate viral loads 6 months apart before that was kind of one of the changes that was made, I guess, when they changed the fibrosis restrictions. So really, you'd taking that off the table, we'd have a couple options, but since that's as payer, you're going to have to wait 6 months from the last one to see. You know, it wouldn't be a bad idea just to check it in between and see what it is. I mean, you could even check it in a couple months and see, but really, I like to have 2 negative tests before I could say they cleared it. But I mean, you know, he could have gotten reinfected, like Greg pointed out. There's also, we kind of use that 6-month mark of saying, well, if you're going to spontaneously clear it 6 months, but remember, people still clear even a year, a couple years out sometimes. It doesn't happen often, but it can still happen. And so, you know, with the fact that his viremia is so stinking low, I probably wouldn't do, you know, getting him treated right now. Now, it's nice because he is engaged right now, so you'd want to tackle it while he's in care, and I definitely see that point. And I think it's really important to talk with him openly about, hey, you're in drug court right now, you're seeing me right now, what happens when you get off? You know, you need to know these are the ways of transmission to someone else, these are the ways of getting reinfected again, which I'm sure you're doing that because I know you're doing that. But focusing more on that for right now, since we really still don't have the capability to get him treated yet. But he, you know, he may even clear. Since you only have 1 technical viral load, you know, right now you're going to have to wait, unfortunately.
Okay.
But you have, I mean, you know, you do have options. The other thing is if he does come off drug court, if you start him on treatment, I mean, sure, even if he takes like 4 weeks, he's probably going to be fine and get rid of this. But I mean, if there's some chance that maybe once he's released from his legal commitments that he may fall like out of care, I mean, I'd be a little bit hesitant to treat him now anyway. I know that from a social standpoint, it's great too, and we want to, but if you're going to lose him to care, and he's going to get reinfected, I mean, you wouldn't really know down the road if he actually got successfully treated or got reinfected. So, I mean, I think maybe getting a feel for him for a little while longer, probably in his best interest too. But you have a couple, I mean, Maverick for 8 weeks, Epclusa for 12. Both are great options, either or.
Okay. Sounds good.
Hey, Joanna, did you give him a prescription for Narcan when you saw him?
I don't know that I did yet.
You might talk to him about that. The only reason that I bring that up is just to tell a sad story about.
Starts reusing, he's gonna more or less.
Well, no. So what happened to me was I ended up with she's a patient of mine who has had substance use, and she relapsed. Anyway, ended up in drug court. I guess as some part of the drug court, they give these people what kind of effectively act like probation officers, but that's not exactly what they call them. It's some sort of like a case manager, caseworker, and that sort of thing. Anyway, so I talked to her about having Narcan, like getting Narcan, because she's abused opiates in the past and has relapsed and sort of stuff. I said, yeah, you really need Narcan. Well, so apparently her person or whatever it is had told her really not to have Narcan because she wasn't comfortable with her, the patient, having Narcan. It's because this idea that it might give her some sort of false sense of security in order to have Narcan, which if you could imagine something any more aggressively stupid, I'd love to hear it. But, and she said that, so I had to have this conversation with that lady with this idea. There's when somebody goes to traffic court, we don't tell them to stop wearing their seatbelt. You know what I mean? Like, it's just amazingly but anyway, so I don't know if anybody else has run into that back from people that have not.
We had a doctor who would not prescribe Narcan for that reason. So, yep, that aggressively stupid campaign continues. So it's not just confined to the probation department, unfortunately. Yeah. I hope our probation officers and drug court officers are smarter than that. I think they are. I've made Greg speechless. Never happened before. Somebody mark the calendar.
Nah, I mean, I don't know. I had good success, with having that argument, but with her. I mean, I won, but it wasn't. I mean, I don't know. It's just it really is kind of a bizarre way to look at things. So anyway, if anybody comes across that, you might find that if you talk to somebody that's in drug court and you talk with them about Narcan and they're resistant, you might ask, has somebody told you not to do this? Because apparently that happens from time to time. I'd never run into that. But anyway.
Yeah. No, it's great to hear it, to get the information, to know what to watch out for. Absolutely. Guys, we are at the end. I hate to turn off questions and discussion time, but definitely bring it next time and send me any questions you have, and I'll make sure they get around. Thank you all. We'll see you guys again soon.
Thanks,
guys.